Hello, everyone. Welcome back again to the fourth International Symposium of Complications in Implant Dentistry. I'm so honored and grateful again to have a dear friend with us in the next session. Dr. Emad Salloum from Syria is here with us. And I have to say, Dr. Salloum was always with us and very supportive from the very first year of this symposium. And I'm so happy that he accepted again to join us in this year's event, which according to the situation going to be virtual. Hello, Emad. Welcome to the Symposium on Complications again, and so happy to have you.
Hello, Omid. The pleasure is mine, Omid. As you know, I'm very grateful and I'm honored to be with you on every symposium. And it's a great pleasure for me to be with such a great line of speakers that you invite every year. And I'm so happy now to be with you on the fourth occasion of your symposium. A little bit sorry that it's a virtual. I want to meet you all, but this is what happens. And I'm so grateful to be with you. Thank you, Omid, for inviting me again.
We are happy to have you, and I'm pretty sure all the audience will enjoy your presentation also this year. And today, Emad going to talk about one of the hottest topics in the field of bone augmentation, which is crestal ridge splitting as a successful and predictable method in horizontal ridge augmentation. So before we start, I would like to have Dr. Salloum's CV for all of you, and then we straightly go to the presentation, and at the end, we will have a short discussion on the topic. Dr. Salloum graduated from Dental School, Damascus University in 1981, where he completed his residency program in oral maxillofacial surgery on 1986. He also attended an extern fellowship training at Emory University and Emory Clinic 1989, 1992, and 1998. He is also a diplomate of ICOI, a board member of Syrian Association of Oral Maxillofacial Surgery, and editorial board member of Syrian Association of Implant Dentistry. Dr. Salloum is an international ambassador for ICOI, ambassador of Digital Dentistry Society, and also a speaker for the British Academy of Implant and Restorative Dentistry. Also have to mention that he's one of the experts at dentalxp.com. Dr. Salloum had been lecturing in several regional and international conferences and published several clinical studies. He's a chief surgeon and director of Salloum Dental Clinic and Training Center. Once again, I'm so happy to welcome Dr. Salloum to the podium. And as I mentioned, the topic that he will present for us is crestal ridge splitting in bone grafting techniques as a predictable method in horizontal ridge augmentation. Emad, the stage is all yours, and we are ready for your great presentation. You can share your screen now.
Thank you, Omid, so much. I'll start sharing my screen. Thank you. Dear colleagues, friends, it's a great pleasure for me to be again on this great symposium, the fourth International Symposium of Complications in Implant Dentistry. When I mentioned this symposium, I really flashback in my mind of great memories. Everybody, I know that all the speakers are seeking to take this reward with them. Unfortunately, this year we will not be able to meet all together, but every time we go, we share beautiful memories in Tehran, great hospitality, a lot of friendship, and a lot of beautiful memories. Those are memories from the first symposium, second and third symposium, which I really appreciate a lot. All his hospitality. I would like to thank you, Omid, for all what you did during those symposium. And I regret that this year, my slide will be empty, just some snapshots from the screenshots that I will keep. But hopefully next year, we will meet again and see each other and have a great time. This year, everybody is from behind the screen, sharing their opinions and their knowledge, and it's a pleasure for me to be with you online this time after this quarantine of the whole world with the COVID-19 2019 crisis. It was bad for everybody. Everybody is locked down, but hopefully it will end by the end of this year. Well, I would like to start with the statement of Winston Churchill when he said that a good presentation or a good speech should be like a woman's skirt. It has to be long enough to cover the subject and short enough to create interest. So I will try to do it on my presentation, which will be, I'll be sharing with you the bone splitting technique as a predictable technique for horizontal bone engineering. As we all know that after extraction, and according to other previous research by Schraub, Cardropoli, and other colleagues, we lose about 40 to 60% of the whole contour of the bone, the height and the width and the whole contour. 40 to 60% of the loss may happen in the first 2 to 3 years. So all the dentists around the world will be facing, especially who are placing implants. We never have implants with the ideal bone. 80% of the cases that we get, they have some deficiency. And most of them, they have horizontal bone deficiency, while we call it narrow ridge. So I will discuss with you, especially with the cases, and it's most recognizable where it becomes, the narrow ridge becomes in the aesthetic zone. And the patients are becoming more demandable about the aesthetics, as well as we are becoming more demandable in our cases to give the best for our patients. Even if we have enough space to place our implants, still any collapse in the aesthetic zone may interfere with the final aesthetic outcome of our implant placement. So all the dentists, implantologists, periodontists, prosthodontists, we all are facing on a daily basis a horizontal bone deficiency. Either we have space for the implant or we don't have space. So if I ask any of the colleagues or the audience, how would you manage those kind of horizontal bone deficiency? I'm quite sure that every one of us will give his own solution or his own technique for solving this problem. But I believe that all roads lead to Rome. But each one of us will start from a point to suggest a new treatment plan. Let's say most of the well-known techniques is the guided bone regeneration, which is widely used by all the dentists, all the periodontists, and it's usually the first line of choice of our treatment plan, either using allograft, xenograft, alloplastic materials, or even autogenous particulated bone. It's a kind of a cooking that we have to achieve. So we add the salt and pepper, which is the powder of the grafting material. We cover it with the membrane. And sometimes we add some sauces like PRF, PRGF, whatever you want, or a BMPs. And mostly the periodontists may, or the sashimi lovers, may add some sashimi connective tissue graft to add value or to have a good solution for solving the narrow ridge. Like this case, this is a guided bone regeneration case solving a very narrow ridge, as we can see here, just solved by simple adding autogenous particulated bone taken from the torus mandibularis here and added to the site, covered with the reinforced piece, and after 4 months, we get a very nice result of bone augmentation for solving this kind of cases. Of course, if we go to GBR history, it's very well documented in the literature with the high rate of success, no doubt about that. Usually we use allografts, xenografts, all those materials that they come in fancy boxes, and we cover with a membrane, with a barrier that isolates our bone graft material from the epithelial tissues. The only limitation of the guided bone regeneration that it has a prolonged healing time, about 8 to 12 months, especially if we are using alloplastic materials or if we are using xenografts. Plus, we get a very high cost, and some patients may refuse those kind of grafts. Some patients would say, I don't want cow in my mouth. I don't want a pig in my mouth. And they even refuse to have allografts material. Even in some countries, allograft materials are not available. Plus, we could lose all the graft material in case of complications. For more advanced dentists or who have more surgical skills, they may use the autogenous blocks to solve the narrow ridges. But of course, it needs more surgical skills and more training to do that. And this is mainly used by oral surgeons. Definitely, in bone blocks, we can achieve very nice augmentation procedures for the narrow ridges. For more skills, oral surgeons or periodontists or even the general dentists who have a special training on surgical skills, they may use the Khoury technique, which is one of the most predictable techniques, and everybody knows what is the Khoury technique. It's obtaining of a block which is splitted in two halves and stabilized by screws, leaving a distance between the recipient site and the cortical plate or the Khoury plate, and that time filled with fully autogenous bone grafts. All kinds of bone blocks, Khoury technique are very well documented with the high predictability and a high success rate. But all those cases, they really require two surgical sites, two surgeries, and with expected morbidity in the donor site, and sometimes more complications with, and in all cases, we need to do it as a late implant surgery after doing the augmentation, which is now the implants are delayed for about 4 to 6 months after using the bone block augmentation procedures. And this is why the patients are not accepting this fact so much, and they get rid of and they just turn off their head because I don't want a long procedure. Of course, the patient's demands are always high. They want no or minimal surgery with the least pain and the least post-operative discomfort, the least complications. They want everything. And on top of that, what they need, what they want is one surgery. They don't want multiple surgeries. What they mean is that everybody would ask me, please, doc, can you do it as a one surgery? Means the augmentation and the implant placement as a one stage. And this will achieve the high patient acceptance. Of course, we as a surgeons, also we have our demands. We always look for an easier procedures, much more predictable and cost effective with the shorter time. And this will produce a high predictable treatment outcome. That's why I will not discuss all the GBR procedures or the block graft procedures. I will just go onto a kind of alternative to those kind of procedures, which is the crestal bone splitting. And I hope that you will find the full benefit of my presentation. As a definition, the bone expansion on the bone splitting technique relies on a fact that it only and merely relies on the advantage of the viscoelastic properties of the bone. This is by definition. The first presentations or the first published paper about the expansion and the splitting cases was published by Simeon and Baldoni in 1992. For the, as they mentioned, in the in the split crest technique, it's necessary to the reception. The vestibule bone segment is deviated laterally using a green stick fracture. And this is the principle of the bone splitting. And at that time, they used special fine chisels, which has been used previously in orthopedic surgery. When I met Dr. Adipalti, he stated that he was the first one who published a paper or who started to do the bone splitting, and that was, according to his statement, in November 1990 on a 17-year-old patient who was involved in a horse riding accident. But the real protocol, which I believe it was put as a protocol, was published by Dr. Mike Picos in 1992, where he put a full protocol using special chisels and special osteotomes with a special protocol in a way to move the buccal plate laterally with minimal trauma and at the same time simultaneously creating an accurately shaped osteotomy for the implant placement. And this has been published in 92. And after the first step of using those kinds of osteotomes, which has, as you have seen, a flat surface from one side and the concave surface from the other side. The next step is to use the same osteotomes or the condenser that had been introduced previously by Tatum, and by using those expanders, there will be a manipulation of the bone to form a receptor site for implant placement without removing any bone. So at the same time, we do the splitting first, as we can see with the special osteotome, and at the second step, we expand the site after moving the buccal plate into a labial positioning. We start gradually to expand our ridge to reach the final size for receiving our implants. So I will try to define two terms. One of them is the bone expansion, which is usually indicated where we have more than 4 millimeters of width of our alveolar crest. So it's not indicated for less. At the minimum, we've got to have a 4 millimeter width of our alveolar crest. And this is what's called bone expansion. Starts with those chisels introduced by Mike Picos and then completed with the same condensers or the osteotomes which had been previously described by Tatum. And this is very well documented in the literature by Asfar and Siddiqui. They used like the screw type of expansion, And as we can see here, so the main indication of this kind of expansion is to reduce the undercuts, where aesthetically, or the cases that require more aesthetics. And sometimes we can gain about 2 to 3 millimeters of extra width so we can place our implant. And the main advantage of this procedure or the expansion procedure is that there is absolutely no drilling. So there is no bone removal. On the contrary, we are condensing the bone and keeping the bone inside. And this is usually a minimally invasive and very cost-effective procedure. And above all, by the condensing our alveolar site, we will be improving the bone density type for better primary stability of our implants. And at the same time, we are improving the aesthetic outcome in the mild horizontal bone deficiency. Of course, the same result we can achieve just by using the new osteodensification technique presented by our friend Dr. Salah Weiss. The same concept of the manual expanding using the expanders, we can expand the alveolar crest by using the Versa or the denser burrs that have been, which is the concept of osteodensification. And according to the literature, there is absolutely no difference between using the manual condensers or the osteodensification technique. It will we can get the same result exactly on the level of the expansion, the limitation of the expansion, and the primary stability of our implants. So the main indication of the expansion, as I mentioned, is that to cover or minimize the undercut, especially in the aesthetic zone, as like this case. This is a patient who came to me who just asking for an implant because she had the conventional 3-unit porcelain fused to metal bridge, and she's one of the very rare patients who came asking for an implant because she thought that her problem or her aesthetic problem is because of the bridge. Of course, all of the dentists could now place a better prosthetic bridge by using new materials, the zirconia or the EMAX procedures. But if you look correctly at the case, the aesthetic problem is not only from the bridge. Her real aesthetic issue is this depression in the alveolar crest. But still, we need to expand this bridge to achieve better aesthetic outcome. As you can see, the depression is coming on all the alveolar area, in spite that we have enough space as a width to place our implants. Just by using osteodensification protocol and expanders, I was able to flatten or decrease the curvature of the alveolar crest, and I was able to achieve much better aesthetic results. An additional bone graft material, only particulated autogenous bone graft, will be more than enough to achieve a very good aesthetic outcome, as we can see here. All the expansion technique is very well documented in the list papers in 2000, and even those are most recent literature. In the last one I could get is 2014 with excellent result by all the authors. The second term I want to show, which is the real bone splitting. And the real bone splitting is only indicated when we have less than 4 millimeters of the width of our crest. So the other term is expansion. We use it if we have a width over 4 millimeters. If we have a less than 4 millimeter width, we start to do what we call splitting. The real crestal splitting needs special instrumentation, which is usually a blade-shaped osteotomes and chisels. Gradually, we use gradual sizes of those kinds of chisels. The old type, and this is a slide taken from my dear friend, Dr. Sartawi. As you can see in the old times, the real ridge splitting was a big surgery because the instrumentation and the hammer use is really invasive. But now, nowadays, after introducing all the technology of the ultrasonic piezo surgery, we are able to achieve the splitting in a much precise and more safe and more predictable way with a very low morbidity in the bone. And this is one of the advantages of the old modern technologies we have. The one other technology that we should always take advantage of is this cone beam CT scan, which is now mandatory to plan all our implant cases, especially to determine when and how we can achieve the bone splitting. So the CBCT will give us absolutely accurate, 100% accurate measurement of our width of the bone, as well as it can determine how much spongeous bone we have, how much is the cancellous component in our ridge. And accordingly, we can plan if we do the splitting or we have to choose another technique to do the augmentation. The main principle of the bone splitting is that there are thumb rules. The first thumb rule is that we've got to have a minimum of 2.5 to 3 millimeter minimum width of our crest to achieve a safe splitting. The second thumb rule is that we should have also a minimum of a 10 millimeter bone height to achieve the splitting. Because if we have a shorter, there's a great ability that we will not get a good expansion, or we will not be able to gain good width, because the angle of the splitting will not be enough to gain a good width. This is first. And second, if it's a short one, as much as it's short, when it's short enough, it will be more chance to get a fracture in our labial plate. The third thumb rule is that we have to know the density of our bone, which means, by other way, how much we have spongeous component. So the splitting technique is only indicated in D3 and D4 bone, and it's limited sometimes with the type D2 bone. So when we achieve a splitting, we are able, if we follow the rules, we are able to achieve extra expansion or extra width by about 2/3 of our height. That's why I insist that we've got to have at least a 10 millimeter height. So in this case, we can gain at least 4 to 5 millimeter of extra width. This is a case that I want to share with you, one of the early cases that I did. At that time, there was no CBCT available in my area, and I counted only on what at that time available, the DentaScan. And this is a case that I had a width about 2.5 millimeter. And on the DentaScan, I was able to see a good amount of spongeous bone. So I'll show you the technique step by step. By using the ultrasonic piezo tips, we are able to achieve a very thin and very neat and accurate cut, osteotomy, into the bone. And we introduce this tip 2 millimeter by 2 millimeter in the depth until we reach a full 10 millimeter. After introducing this piezo tip into 10 millimeters, we are able now to start to introduce our chisels. In the maxilla, most of the time, there is no need even to use a hammer. Just by hand pressure, we are able to start to achieve the first splitting and the expansion of our alveolar crest. As you can see here, we start with the 1.5 to 2 millimeter chisel that has a flat side, and then that has a concave side from the other side. It will be facing the labial plate. As you can see here, this is the shape of the osteotome. After that, we gradually introduce the second size, which is 2.5 to 3, and then this is the osteotome of the size of 3.3 millimeter introduced to the full length of our splitting, which means at least it's a 10 millimeter. In that case, we are able to achieve the first steps of splitting, and we are able to get about 3 millimeter extra expansion in our ridge. Then, slowly and gradually, we introduce a wider osteotome into the site to achieve about 5 millimeter of splitting. At this point, we start to use the condensers or the osteotomes or the expanders of our system by simply introducing with the hand pressure slowly and gradually. We are not in a race, we are in a marathon. So just gradually and slowly, and introducing only by hand pressure in the maxilla, we are able, as you can see, to achieve a good width. This is an osteotome or a condenser of a size of a 3.8 millimeter implant, which corresponds exactly to the shape and the diameter of my future or my planned implant to be inserted at the same site. And those osteotomes are inserted exactly at the same site that we are planning to place our implants. So at the same time, we are doing the final preparation of our implant site bed to receive our implants. By the end of the procedure, we are able to achieve a 7 millimeter width for our implants. And 7 millimeter is more than enough to place a 3.8 or a 3.5 to maximum 4 millimeter implant, which is more than enough to get all the loading that we want, even if we have a minimum of a 10 millimeter height. As you can see, we are able to insert our implant properly in the position we exactly want. Then, if we have a void or a space between the two plates more than 2 millimeters or 3 millimeters, we can pack this space with the material of choice. I would personally prefer an autogenous bone graft, or if it's not, if we cannot collect, in this case, I collect some autogenous from the basal, from the base of the, from the alar bone, and the next preferable is the allograft material. But we can use the material of choice. In this short clip, I would like to share with you to see how much it's sometimes easy to do the bone splitting. This is the case just by introducing the osteotome. We are able to achieve a very thin and neat green stick fracture. And then the void area will be filled with the graft material. And as you can see here, I was able to place another implant with a very good primary stability in the splitted area. This is a case where I was encouraged to do it after some experience, that I started with about a 2 millimeter, and by the end of the splitting, I was able to achieve a 7 millimeter width in this case, which is more than enough to place my implants simultaneously. And this is the main advantage, of the crestal splitting technique, is that we are reducing the time for the patient, and we are able to place our implants simultaneously. I want to share another case, which is a fully edentulous. As a mean width of this bone, it's about 3.2 millimeters. The same steps after the piezo tip splitting along the whole crest started gradually expanding, and then using my surgical guide, I just mark with the pilot drill the place of my implants, and then I start to introduce my condensers. By the end of the splitting, I was able to insert my implants. Those are 3.8 millimeter diameter implant, and as you can see, the final result, we can be able to achieve 7.5 to 8 millimeter width and place our implants simultaneously. Of course, in the maxilla, maybe it's a much easier task than the mandible. The mandible, we go on the same procedure with the same steps, with an exception is that because the mandibular bone has a more dense bone with a more cortical component and less spongeous component. So we have to add two vertical bone osteotomies to the labial plate, and this osteotomy is also achievable by the piezo tip, not exceeding the cortical plate. So just the same crestal splitting osteotomy by the piezo, we just add two vertical osteotomies in those cases, and we proceed with the same insertion of our osteotomes, special osteotomes, but in the mandible, we may need 2 or 3 knocks with the chisel and the hammer to achieve the first splitting. And here we should take very good care in introducing our osteotome. That's why I insist on achieving the first split by means of using the piezo tips, which opens the area for the real accurate accurate site or accurate pathway to introduce our first osteotome. And gradually, we can achieve the same kind of splitting just by using the condensers and the osteotomes. Nowadays, after the splitting, it's favorable to cover the area with the collagen membrane, especially if we are using alloplastic materials to fill the voids. To achieve a better or easier for the patient with more comfortable way to the patient, some companies innovated some kind of tools, special tools to achieve the splitting after the insertion, after the first osteotomy, to insert special spreaders instead of using the hammer and the osteotomes. And they work very well. The most kit that I personally prefer, and it's the most widely used, I think that all over the world, is the screw expanders, which are used with the splitting technique. And this is the kit that I usually use. It has the expanders and the osteotomes and the blade osteotome kits and all the screw expanders that are used directly after the splitting. So the technique is after the initial splitting with the piezo tip or the initial osteotomy with the piezo tip, those expanders, those are screw expanders, are inserted in the exact positioning of our planned implant sites. So we introduce gradually size after size. We start with the 1.8 millimeter screw expander, and we end up with the about 4 millimeter expander. Those will achieve, as we can see, gradual expansion after the splitting, which kind of a green stick fracture or expansion to the mandibular bone. And this is one of the most safe techniques to do a gradual expansion in the mandible. Of course, we can use it in the maxilla also, but it's mainly used in the mandible. So we decrease the ability or the possibility of using the osteotome and the hammer. And by the end of the splitting and the expanding with the screw expander, we are able to place our implants simultaneously. And in this case, I would really advise, and according to the system you are using, it's recommended that to place those implants 1 millimeter subcrestally and to fill all the space with the grafting material of choice and cover with the membrane and do the final suturing. I will share with you, this is a live surgery of one of my cases. After a full thickness flap, even I have a CBCT, I still have to make a bite that I have away from the anatomical landmarks, which is the mental foramen and the inferior alveolar nerve. And as you can see, I made two transverse osteotomies limited only to the cortical plate. Next step is I place my surgical guide just to make it, and using the pilot drill, just to do the marking of my suggested implant site to be placed. I start only with the pilot drill to the full length that I need to place my implants. After doing the first initial drilling, we start to insert the screw expanders at the same site of our planned implant. And by gradual inserting those expanders, by gradual sizes, we started, as I mentioned, with the 1.8, and we end up gradually with the 3.5 millimeter to 4 millimeter expansion. Usually I keep one of the expanders in one side, and then I insert the larger one in the other side of the implant. So I get a really slow, this is a very slow procedure. As I mentioned, we are in a marathon, we are not in a race. And as you can see here, encounter the vertical releasing osteotomy cut that I made in this area. The final step, that I can insert my implants with a very high stability. Just by the handpiece, you can encounter that I didn't need so much torque. The final torquing and the final insertion is done by using the wrench and torque. And if we don't have a big gap, we just leave it. We don't need to do any bone grafting material unless we have a big gap. The final suturing as a watertight suturing, and the final results are always great. And this is the main advantage that I mentioned, that we were able to do the augmentation at the same time, simultaneously placing our implants. And this is the biggest advantage in this case, which is minimally invasive relatively to other procedures. As a research, since 2000, several papers had been published on this technique. And they showed all that in the most cases, a dental implant can be immediately placed during the ridge splitting, and this implant will heal just normally in the bone, as if it is a straightforward implant placed in a fully matured bone. Other studies had been also published, which is showing how much predictable the splitting technique. And so as we can see here that by means of using this technique, we have a very good bone regeneration surrounding our implants, because all our implants is totally embedded in a highly vascularized, mature spongeous bone with a very high primary stability. So, and in most cases, we don't need to graft all the void area, because all the implant is filling all this area. If there are residual more gap, we can fill with the any kind of material of your choice. And the most important is that the total recovery time from starting the surgeries by means of doing the surgery of splitting and inserting our implant simultaneously up to reaching the prosthetic phase, it's the whole period is not more than 6 months, and usually it's not more than 4 months, especially in the mandible. So we can go after 4 to 6 months to our prosthetic phase, and this is one of the big advantages. And as you saw from the technique, is minimally traumatic. It's minimal trauma because our expansion and splitting is a gradual controlled expansion with absolutely no bone loss, because we are not doing any drilling. We are just introducing our expanders through our prepared site. And just by expanding, we are able to prepare our osteotomy site to receive our implants. So there's no drilling, there's no thermal injury, and we are able to place our implants immediately. And this is one of the advantages that the patients would highly appreciate. And this technique can be used with almost all commercially available implants. And in most cases, we do not require any additional grafting or expensive materials to be. That's why it's very cost-effective method in dealing with cases of narrow ridges. Edward Anitwa in 2013 published a very nice paper showing he inserted 37 implants in 20 cases, and he measured the extra bone width that he gained in the crest and in other areas of the alveolar ridge. And as a result, the mean expansion in the current study was about 3.5 millimeter extra bone width that we can gain extra to place our implants. So if we started with the alveolar ridge with the 3 millimeter, which is the minimum to do the splitting, sometimes in very soft bone we can start with the 2.5 millimeter, but at least we can gain between 3.5 and 5 millimeter extra bone, which is more than enough to do and to place our implants simultaneously. And let's pretend that in case of occurrence of a malfracture following the split crest, this will not reduce the gain of the bone quality. And according to his study, there were no cases of failed implants or complications. Well, as every technique, there are some disadvantages and some limitations. So we have to be very careful in choosing the technique according to the indications. So the first one, as I mentioned, that we have to the ridge should have enough cancellous bone compartment between the buccal and the lingual component. So then we have to shift to another technique. There is some kind of resorption to the labial plate if it displaced labially, especially because we are raising a flap. And the bone splitting technique, one of the big limitations that it's not if we have a case with the horizontal bone deficiency and vertical bone deficiency. So if we have both, of course, we have to choose another method of bone engineering or bone augmentation. So it's only indicated if we have only horizontal bone deficiency, and if we have a good amount of spongeous component, that's how it's totally contraindicated in D1 bone in a very high dense bone. Of course, we can get some complications during surgery. There's no technique without any complications. One of the complications that we may not be able to fully mobilize the vestibular plate, and this is very rarely happens in the mandible if we did not apply the rules of this technique. And sometimes, in very rare cases, the vestibular plate or the lingual plate that had been separated, it could be break off or fractured. In this case, we have to shift and use it as a block graft. We don't stop the procedure. So we can just use this separated labial plate as a block graft. And we have to be very careful. One of the complications is that the injury of the inferior alveolar nerve during the hammer use or so, which is extremely rare if we take cautious of the technique. And the outcomes, according to Ishida and his co-workers, that mandibular bone expansion in conjunction with root form implants with the case reports he presented, in which that even if we get a fracture, the malfractured segment can be easily turned off to a free cortical block. And according to his study, if the surgeon was able to do it, he is totally able to go on and proceed with his implant case with no failing implants, according to his study. There are some late complications, of course, and this is one of them that happened with me. After placing the, after doing the splitting and the implants had been fully osseointegrated, and during the management to achieve, to go on for the second surgical phase, which is placing my healing collars, just extended the flap a little bit to see, and I was able to see that a resorption has occurred in the labial plate. This is easily managed after by doing just a GBR procedure, adding some bone. In 2014, Andres Stryker suggested a technique which is called the bone splitting stabilization technique. By means of directly after splitting and after inserting our implants at the same time, we add an onlay graft material, particulated graft material of your choice, and most of them, they use xenograft because the xenograft is very slow resorbable, so it will maintain the buccal plate and it will keep the buccal plate from resorbing. So we just simply, after doing the splitting and placing the implants, we add additional bone graft material and we cover with the membrane as if it's a GBR procedure, and this is called the bone splitting stabilization technique. And the end results after 2 years, as you can see here on the CBCT, and that the labial plate had been maintained 2 years later on, and this is the final prosthetic work. So it's a very effective technique. It will stabilize our labial plate, and it will decrease the complication of the resorption of the buccal plate. And accordingly, and according to André Sticker, he stated that the hard as well as soft tissue structure revealed very favorable and stable result with the follow-up for 2 years using the stabilization technique, which is the adding the bone grafting material to our labial plate. I will come to the final conclusion of my presentation, that the bone splitting technique is a highly predictable, with the reduced trauma and with a very high success rate of our placed implants. And even not only placing the implants, even the final prosthetic restoration has a final functional and aesthetic results, excellent functional and aesthetic results. This is compared to other alternative elements of bone graft or soft tissue manipulation. I want to share with you also the just small comparison between the guided bone regeneration technique versus block graft technique versus ridge splitting technique. As we can see that all the GBR procedures for doing the horizontal bone augmentation, they need 2 surgeries and more trauma. The bone block grafting, you need 2 surgical sites with 2 surgeries, while the ridge splitting technique, 1 surgery, 1 surgical site, and we get more patient acceptance. In fact, all the patient would accept because it will go with them as a regular procedure of implant placement with just 1 surgery and 1 surgical site. And this is the main advantage. This is with the limitation of the indications of this technique. So my take-home message is that there's no one treatment modality that fits for every case. Of course, in some cases, we choose the bone splitting. In other cases, we may choose the GBR or the Khori plate or any kind of other modality to solve the problem of the horizontal bone deficiency. So we have to have in our toolbox multiple management modalities. So in case of complication, even in case of complication, as I mentioned, if it gets fractured, we should have in our toolbox all the equipment, all the knowledge to proceed our procedure with another technique. And we should always rely on predictable and reproducible techniques. We should follow the rules, no shortcuts, and this is very essential. And when applying a technique, we should know how to handle its complication. I will not criticize any technique. I will not encourage any technique in purpose. I just show that ridge splitting is one of the most reliable techniques with the limitation and the indications if it's used in the correct indication. But for me, do whatever works best in your hands. Of course, all kind of advanced bone augmentation procedures, including the crestal ridge splitting, they are user sensitive, and advanced training is highly recommended. Never count on YouTube films or YouTube surgery and think that we can learn from YouTube or Facebook. Facebook and YouTube's, they are good informational platforms, but they are not educational platforms. So we have to go and take courses, which is available all around the world by very well known organizations, and we should go for those courses. I hope that I covered quickly and clearly my subject, and I would like to invite you all next time to come to visit me. This is my area. I live in a place on the very beautiful city on the Mediterranean. It's called Tartus. I would like to invite you all to come to visit my place. We can share very good time together, and we share knowledge all together, and see you in my center. And with this beautiful sunset from my area, I would like to ask you all to stay safe and stay home, please. And thank you for your kind attention.
Thank you so much, Emad, for your very comprehensive and focused presentation on the topic of ridge splitting. Actually, you truly showed the steps and from the very beginning how this technique started and how it changes over the years with different technologies, with different instruments. And what I really liked about the presentation, because it's very important to know about the complications that may happen during each procedure. And when we have enough knowledge to be able to prevent the complication, then, as you mentioned, all techniques can work And it's really important to know what are the real indications of each technique and to know what technique works best in what situations. So we will be able to, as Dennis Tarnow states all the time, that to be able to know what banana you should pick out of your pocket, you know, you should have lots
Yeah.
but you know, in each
Exactly.
different bananas are, you know, important to know and differentiate between them. So Emad, one of the cases that you mentioned, especially I think it was in the upper part of the maxilla, and you mentioned in one of your slides that a minimum criteria for being able to do the ridge splitting is to have about 2.5 to 3 millimeters of ridge width. And as you mentioned, you need to have at least 10 millimeters of height to make sure
Correct.
the fracture won't happen at the base of the ridge. So my question is, because it's very interesting, at least in my mind, that when we want to do ridge splitting, usually if we have 5 millimeters of ridge width, but the direction of the ridge is toward to the palate or the lingual because of the resorption of the spine, then we can correct the direction of the ridge and then
Absolutely.
place our implants. And when it's 5 millimeters, there will be lots of or adequate bone around our implant, so that's fine. But when we have less than 4 millimeters of bone width, and if we do the ridge splitting, the remaining bone on the buccal and lingual aspect will be almost 100% cortical bone.
Of course, yeah.
Especially in the coronal part of the ridge, not in the middle or the apical part. So,
yeah.
And also, as you mentioned, one of the advantages of ridge splitting is that it makes the surgeon able to place the implant simultaneously. Now,
this is the main advantage. Yeah.
Now, my question is this. When we place our implants simultaneously into a ridge that mostly the bone on the buccal and palatal aspect is cortical, and you're forced to do the GBR on top of that bone because it's very thin. So my question is, how will be the vascular supply to the bone graft material that we put on that piece of thin cortical layer of bone on top of our implant?
I think that it will come from the covering periosteum. There's no other way. And even still the cortical plate, it's still attached. It's still attached. So it has a vascularity, I'm sure. In some cases, there are now new innovations to do the crestal splitting. I didn't show because it will be a very, I will exceed the time. There are now new techniques that you can do the splitting flapless, So you can do it with the special piezo tips and special piezo kit. So you can do the splitting accordingly, just flapless, just a small incision on the top of the crest, and you go with those splitters, piezo splitters, you can achieve that. But even if you expose a flap and you do the additional bone, I don't think that, according to the literature even, there's no problem. This will be a protective added. This added bone graft is mandatory to protect the alveolar, the labial plate from resorption. I think that all the integrity or all the blood supply will come from the periosteum, I think, of this material. It's like any GBR procedure. It's not just mainly like any other GBR procedure, only GBR procedure.
So because the reason that I asked the question was that because we put the membrane on top of the particulate graft, so in that case,
you think that, so you think that the difference between the two cases is that if you are using a GBR procedure, that you sometimes decorticate, you mean the the site. I think that by doing the splitting, all the sponges component of the alveolar crest is now exposed and open. So I think that this will give an extra blood supply to the additional graft material. It's like doing the cortication, so the upper end will be enough, I think, of giving some blood supply.
Yeah, you're right. And one more thing that I wanted to add was that especially in the mandible, you showed one of the kits. Actually, I saw those kits, but I haven't worked with them. The one that they have some kind of screws and there are two plates when you put it in the area. And did you find it easy to work with? Because the way that it seems on animation, it cannot maybe work on the patient mouth. I don't know. I want to know your experience about it because I didn't work with them.
In fact, me too, I didn't work with them. When I saw the screw expanders, I didn't even try them. So personally, I have no practical experience with those. Just I have an idea, but I think that, as you mentioned, they are not easy to handle or easy to use.
Yeah.
Because so many tools you have to insert and other. So I find that the screw expanders are more practical and more reliable. And at the same time, those expanders, the screw expanders, at the same time, they are preparing the bedside of the implant to receive the implant. And this is another advantage.
And my final question is this. When you're using the expanders, the screw expanders, do you use them with the ratchet or with the motor-driven ones? Because they have adapters, so you can place them with the motor.
Of course. As you saw from the video, I start with the handpiece wrench. Mm-hmm. When it comes to a point that it's stuck, of course, I will not apply very high torque on my handpiece. So I would prefer to control the torque by hand and then insert it slowly. And you have to let the bone for about 10 seconds to 20 seconds to relax after doing each step. And every size I put, I keep the first size in one of the holes, and then I take it out anti-clock rotational. When I insert the second size, I keep it inside just to give the relaxation. Then I insert in the other preparation side a wider one. So I keep one, I shift between the two sizes, between several sides of the osteotomy places. So I give the bone time to relax, and this is mandatory because what we need is a slow expansion with some kind of green stick fracture and keep everything, keep the labial buccal plate attached and keep the lingual buccal plate attached just by pressing. And there is enough viscoelasticity in the bone. Of course, if we have a spongeous bone. If we don't have that, that means all the technique will be will end into a disaster. Yeah. But if it's used in its indication, we are able always to achieve at least 3.5 millimeter extra width of our implants, our width.
You're right. Thank you so much, Emad. I think it's a very interesting topic and we can talk about it like hours, but as you know, the time is limited. So I really truly enjoyed your presentation and thank you for the discussion. Thank you for your time. Hopefully next year I will give you your Oscar. So the ISTS.
Yes.
Yeah, but
I will get 2 Oscars next year. Okay.
So this year,
so keep the collection for me.
Yeah.
I'm keeping your XP hat for you.
Yeah, good.
Okay.
So, thank you again for your time and really hope to see you very soon. Stay safe, as you said, and God bless you. Thank you again, and bye-bye.
Bye-bye. Thank you, Omid, for hosting me again, and I hope to see you very soon, and we will meet shortly. Until then, please stay safe and God bless you.
God bless
Thank
you.
you again, Omid.
Bye. Thank you.
Bye-bye. Thank you.